Hello everyone and welcome to our module on movement disorders. First group of movement disorders we'll discuss are tremors, and you can divide tremors up into those that occur at rest and those that occur with action. Among the tremors that occur with action there are a couple of subtypes. The first type is a postural tremor. This is a tremor that occurs when a body part is held against gravity. So the classic example of this is a tremor of the hand that occurs when you hold the hand straight out in space. But when you rest the hand against the side, it goes away. That's a postural tremor. Kinetic tremors are tremors that occur with voluntary movement, and the most important form of kinetic tremor is an intention tremor. This is a subtype of a kinetic tremor, and it's called intention because it usually involves the hand, and as the hand approaches its intended target, the tremor gets worse. Resting tremors are usually due to Parkinson's disease or some Parkinson's disease variant, and I talk about these disorders in another video. The tremor of Parkinson's disease is described as a pill-rolling tremor. It occurs at rest and the patient looks like they're trying to roll a pill between their fingers. This tremor improves with movement, and it's a relatively low-frequency tremor, usually about 4 to 6 hertz. So a tremor of 4 hertz means there are 4 tremors per second. That's a relatively slow speed. A physiologic tremor is a postural tremor that occurs in normal patients and is caused by increased sympathetic nervous system activity. The classic example of this is anxiety. Many people, when they have to speak publicly, for example, become anxious, and if they hold their hand out in front of them, it will shake. That's a postural physiologic tremor caused by anxiety. This is usually a relatively high frequency tremor, usually about 10 to 12 hertz, so lots of tremors per second. Essential tremor is a nervous system tremor disorder. The old name was benign familial tremor, and it got this name because this disorder tends to run in families, and it's benign, meaning it does not indicate Parkinson's disease. It usually involves the arms and hands. It's worsened when the arms are outstretched, so it has features of a postural tremor. It also tends to significantly affect writing and make it hard for patients to write. In addition to the arms and hands, some patients have head shaking, and usually it's a bilateral tremor involving both extremities. Essential tremor is activated by voluntary movements, so you can provoke this in the office if you ask the patient to do finger-to-nose testing. It's a relatively high-frequency tremor, usually 6 to 12 hertz. It's often described as a fine tremor as compared to a coarse tremor, which is a slower tremor. And then essential tremor is famous for being improved by alcohol, and patients may self-medicate. They may say that they find when they have a few drinks the tremor gets better. Essential tremor has a genetic predisposition, so it tends to run in families. That's why it used to be called benign familial tremor. And when patients develop an essential tremor, the number one thing on the differential diagnosis is Parkinson's. That's what everybody worries about. Some of the differences between ET and Parkinson's are that essential tremor is much more common, so it's a more likely diagnosis. Parkinson's usually occurs in older patients, whereas essential tremor can develop in young patients. And then the tremor of Parkinson's and essential tremor have opposite effects of rest and movement. Parkinson's is a resting tremor, whereas essential tremor gets worse with voluntary movements. There are a number of drugs that can be used to treat essential tremor, but the most common one and the one you should know for your boards is the beta blocker propranolol, which is often very effective for essential tremor. Beyond this, there are other drugs that can be used, including some anticonvulsants. There are even surgical options in severe cases, but propranolol is the usual first-line therapy. Next tremor is intention tremor. This gets its name because it occurs with intentional action. It usually involves the hand, and the tremor is usually perpendicular to the movement of the hand. So for example, this person in this picture is trying to reach the glass here, so usually the tremor will be in the perpendicular direction, sort of left and right from the direction of movement. The defining feature of this tremor is that it worsens as the hand approaches the target, and then the hand also often over or undershoots the target. And when you see a description of intention tremor in a board question, it always means there's cerebellar disease. It's cerebellar outflow disease caused by some problem in the cerebellum, either stroke, multiple sclerosis, or something else. It's often a unilateral tremor, and that's because lesions of the cerebellum tend to affect the left or right side, and that causes the tremor to be on one side or the other. And it's described as a coarse tremor because it's relatively slow, usually in the range of 2 to 4 hertz. If you ever get to examine a patient with an intention tremor, it almost looks like their hand is swaying left to right and just missing the target. It's actually a tremor, but the tremor is just so coarse and slow that it looks like a swaying of the hand more than a fine, shaky tremor. Functional tremor used to be called psychogenic tremor, and it's a form of functional movement disorder that does not have a clear underlying neurologic basis, and therefore it's called a functional disorder. These patients have abnormal involuntary movement consistent with a tremor, but there's no evidence of any known neurologic cause. The tremor usually has an abrupt onset and it immediately becomes maximally severe, and most of these patients have a history in their past of emotional or physical trauma. Functional tremor is somewhat similar to conversion disorder in that respect. And the hallmark of functional tremor, and the way you can always recognize it in a board question, is it improves with distraction. So if you distract the patient, the tremor gets better. They have to be thinking about the tremor for it to get worse. And the clinical features of the tremor can vary in terms of how fast or slow it is or the situations that bring it on. Okay, our next movement disorder is myoclonus. Myoclonus refers to brief shock-like involuntary movements. Myoclonus can occur in normal patients, and when it does, it's called physiologic. This is common as people are falling asleep. You may have had this yourself. I had a friend in college who once fell asleep in lecture and had myoclonus and knocked his coffee all over his lap. Essential myoclonus is similar to essential tremor. It's a neurologic disorder. It can be hereditary or it can be sporadic, and it's called essential myoclonus only when there is no other neurologic illness going on that might explain the disorder. If patients purely have myoclonus, no other neurologic deficit, then that's essential myoclonus. And then lastly, patients with epilepsy can have myoclonic seizures, and I talk about this in the video on seizures. Fasciculations are small, local, involuntary muscle contractions. They're often apparent under the skin. Usually these are benign, but they can be seen as an element of patients who have lower motor neuron lesions, and I talk about this in more detail in the video on spinal cord disorders. In addition, fasciculations are a classic feature of amyotrophic lateral sclerosis. I also talk about this disorder in the video on spinal cord disorders, but ALS involves lower motor neuron lesions, and therefore you can see fasciculations as an element of the disorder. Our next movement disorder is chorea. Chorea refers to involuntary, brief, random, irregular contractions. The easiest way to think about chorea is that the patient appears restless, as if they constantly need to move, but the patient is not doing that voluntarily. It's an involuntary motor problem. Chorea can be idiopathic. It can also be a hereditary disorder. It can also be part of another disorder, and we'll talk about some of those in just a minute. And chorea is really part of a spectrum of hyperkinetic movement disorders called choreiform disorders, and I've written some descriptions of those down at the bottom of the screen. So we've already talked about chorea. Chorea often goes together with athetosis. Athetosis is slow, writhing, snake-like movements. If you go to YouTube and search for athetosis, you can see affected patients who have this. They are constantly moving, but their movements are snake-like. And chorea and athetosis often occur together, and when they do, it's called chorioathetosis. And then lastly, ballism refers to large amplitude movements of the arms and legs. Basically, the patient will be flinging or kicking their arms and legs. That is ballism. So hemiballism is flinging movements of the limbs, but only on one side of the body. That's why it's called hemiballism. And this classically occurs when there's a lesion of the subthalamic nucleus, which is part of the basal ganglia. This will result in hemiballism, and this often occurs secondary to a stroke. Sydenham's chorea is a form of chorea that occurs in children who have rheumatic fever. Rheumatic fever is a consequence of group A strep infection, usually strep pharyngitis. It's believed that antibodies produced in response to strep infection react with neurons, and that's what leads to chorea. Shown on this slide are the Jones criteria for diagnosis of acute rheumatic fever. To make a diagnosis, you need 2 major criteria or 1 major and 2 minor with evidence of strep infection. I won't go through all of these criteria, but I just want to point out that one of the major criteria is chorea, and that refers to Sydenham's chorea, which is a consequence of group A streptococcal infection and acute rheumatic fever. Huntington's disease is a rare neurologic condition that causes chorea among other neurologic symptoms. It's an inherited autosomal dominant disorder that causes degeneration of the striatum, which is part of the basal ganglia. The striatum is made up of the caudate and the putamen. When you lose this part of the basal ganglia, you lose GABA-producing neurons, and GABA normally inhibits motor activity. So when these neurons are lost, you get excess motor activity, and that includes chorea. In brain imaging in patients who have late forms of Huntington's disease, you will see degeneration of the caudate, and the caudate is right next to the lateral ventricles, so what will happen is the lateral ventricles will appear large on imaging. On the screen is a patient with Huntington's on the left and a normal patient on the right, and hopefully you can appreciate that these ventricles are larger than normal. Huntington's is caused by a mutation in the HTT gene, which is found on chromosome 4. This gene contains a number of CAG nucleotide repeats. A normal gene has only about 10 to 35 repeats. In patients with Huntington's, the gene has excessive numbers of repeats. It can be as many as 120. And the number of repeats in the gene can increase from one generation to the next, and that makes the disease come on earlier. So this disease exhibits what's known as anticipation in genetics. That means the symptoms come on earlier and are worse with each successive generation, and that's because of the accumulation of these repeats. And because this is a genetic disorder, the diagnosis is made by genetic testing. So the clinical features of Huntington's disease are shown in this slide. The onset of symptoms is usually in the 30s to 40s. Death occurs after 10 to 20 years. One of the major features is chorea, but in addition to that, patients can have behavioral changes. They can display aggression, depression, they can also display dementia. And sometimes this can be mistaken for substance abuse until a family history is obtained and the diagnosis is made. There's no cure for Huntington's disease, but you can treat the chorea. And the idea behind these treatments is that dopamine levels in the central nervous system are associated with chorea, and if you can decrease central nervous system dopamine, the movement symptoms of Huntington's will get better. The two drugs that are used for this purpose are two very old drugs called tetrabenazine and reserpine. These drugs inhibit VMAT, which is the vesicular monoamine transporter. What VMAT does is it picks up dopamine and packages it in vesicles in neurons, which will then be released and allow the dopamine to go into the synaptic cleft. So by inhibiting VMAT, you limit the amount of dopamine in vesicles and the amount released into the clefts of the synapses in the central nervous system. Second-line drugs are antipsychotic drugs, which are dopamine receptor antagonists, but tetrabenazine and reserpine have been used to treat Huntington's for a long time, and they remain the first-line therapy. In the video on antipsychotic drugs in the psychiatry section, I talk about tardive dyskinesia. This is an adverse effect of long-term use of antipsychotic drugs that block dopamine. And one of the dominant features of tardive dyskinesia is chorioathetosis. Patients who have this problem will constantly be moving their mouth, tongue, face, and limbs. They have those snake-like movements of athetosis as well as the restless, constant movements of chorea. If you get to meet one of these patients, it's the elements of the face that are usually most noticeable. These patients are constantly smacking their lips and grimacing. And unfortunately, this is often an irreversible adverse effect of antipsychotic drugs. Stopping the drug does not help. Our next movement disorder is a dystonia. Dystonias are involuntary muscle contractions that are sustained and prolonged. And this is in contrast with myoclonus, which we talked about earlier. Myoclonus is also a muscle contraction, but myoclonus is a rapid jerking muscle contraction, whereas dystonia is sustained and prolonged. And one of the classic examples of dystonia is writer's cramp, which you may be familiar with yourself. Dystonias can be focal, like writer's cramp, or segmental, involving a portion of the body. And in general, they are usually associated with overuse of muscle groups. So on this slide, I've listed some common dystonias. So many patients develop a cervical dystonia involving muscles in the neck and shoulder. This is sometimes called spasmatic torticollis. And in patients with a cervical dystonia like this, their neck is turned and their head is tilted, and it's kind of stuck in that position from this sustained prolonged contraction that they cannot release. Blepharospasm is involuntary blinking or eye closure. Some people have this form of dystonia. Spasmodic dysphonia involves muscles related to our speech, so patients with this problem have a voice that breaks, that interrupts their normal speech. Oromandibular or lingular dystonias involve jaw clenching or tongue protrusion that the patient cannot release. And then there are a number of task-specific dystonias. One of these is writer's cramp, which I just mentioned. Musicians can develop a dystonia, and these are all related to overuse of the muscles of the hand. Many dystonias resolve spontaneously if given time, but for those that don't or those that are particularly bothersome to the patient, there are a couple of treatments that can be used. There are lots of drugs that have been used to treat dystonias. I've listed some of the most important ones on this slide. For dystonic reactions that occur secondary to antipsychotic drugs, the two first-line medications are benztropine, which is an anticholinergic drug, or diphenhydramine, which is an antihistamine. It's very high yield for your board exams to remember these two drugs. They're used anytime someone develops dystonia secondary to an antipsychotic drug. For other dystonias, what's often tried is a small oral dose of levodopa-carbidopa. This is a drug used to treat Parkinson's disease, and it will resolve some dystonias completely. Some dystonias respond very nicely to this therapy. And then lastly, botulinum toxin can be injected into muscles that are part of a dystonic reaction. Botulinum toxin causes flaccid paralysis, and it will relax the contracted muscle, and this often resolves the dystonia. Stiff person syndrome is a disorder in which patients develop progressive muscle stiffness, rigidity, and spasms. It usually involves the axial muscles, so these are muscles near the center of the body, things like the lumbar muscles, the trunk, the proximal limbs. And when these muscles become stiff and rigid and spasmodic, it makes it very difficult for patients to walk. The exact cause is unknown, but it's likely related to impaired GABA activity. GABA is an inhibitory neurotransmitter, so when you lose GABA activity, neuromuscular function becomes overactive, and it's thought that that's what leads to stiff person syndrome. There's a lot of evidence for an autoimmune origin of stiff person syndrome. It's more common in patients who have type 1 diabetes, and then many patients with stiff person syndrome have certain types of antibodies. Some have antibodies against GABA neural pathways, and others have anti-GAD antibodies, which are anti-glutamic acid decarboxylase antibodies. The diagnosis is usually based on the clinical features plus supporting evidence. You can perform electromyography or EMG, and there are certain findings consistent with stiff person syndrome. The presence of anti-GAD antibodies suggests stiff person syndrome. And then lastly, this disorder usually responds to benzodiazepines, so if the patient gets better with benzos, that indicates the diagnosis was most likely stiff person syndrome. So the first-line treatment is benzodiazepines. Usually diazepam or clonazepam are used. A second-line therapy that can be used is the muscle relaxant baclofen. We'll finish this video by talking about restless leg syndrome. Restless leg syndrome is an uncomfortable urge to move the legs, and the urge is relieved by frequent movement. This usually occurs during rest or inactivity, especially in the evenings. The classic scenario is a patient who gets into bed at night to go to sleep or read a book and develops the uncomfortable urge to move the legs. This can be particularly bothersome to a partner or a spouse. For reasons that are poorly understood, restless leg syndrome is often associated with low serum ferritin. It's not clear why patients with RLS have this finding, but it's very consistent in studies, and so in a patient with restless leg syndrome, you need to check the ferritin and evaluate them for iron deficiency. The diagnosis is clinical. The treatment includes iron replacement if the ferritin is low and the patient has evidence of iron deficiency. There are a number of simple behavioral interventions that can help. Patients who exercise tend to have less restlessness at night. Patients who reduce their caffeine intake have less restlessness at night as well. There are a couple of drug treatment options. You can use dopamine agonists. These are drugs like pramipexole and ropinirole. You can also use neuropathic pain drugs. These include gabapentin and pregabalin. And that concludes our module on movement disorders.